بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. Our third session for today. First of all, I would like to thank the organizing committee for inviting us to moderate this session, which is going to be part of an interventions, and my colleague Dr. Abdul Qadir Al-Ganawi, consultant intervention radiologist at the National Guard. Myself, I'm Dr. An-Nami. We would like to introduce our first speaker, in which this part will contain about 3 topics. Dr. Sajid Hassan Bhat, consultant musculoskeletal radiologist at the Royal National Orthopaedic Hospital at Stanmore, UK, and he is an author and co-author of several scientific research studies published in the national and international scientific journals, with his first topic, which is going to be in the radiofrequency ablation of osteoma technique, perils and pitfalls. Please welcome Dr. Said.
Thank you very much, Mr. Chairman. Bismillahir Rahmanir Rahim. My sincere thanks to the organizers, Dr. Radadi and Dr. Al-Hajeli, for inviting me to speak at this auspicious conference. The topic which was given to me was the one technique which I practice and use in Stanmore, and this is the radiofrequency ablation for benign bone tumors, predominantly osteoidosteomas. Our hospital is located in north part of London. So map of London is, if you consider a squarish circle, Heathrow is somewhere in the west of the town. If I can get to use my mouse, there we are. That's Heathrow, and we are around here in the northwest part of London. If I just mag that up, that's the hospital, very close to one of the big motorways which connects London to the north of the country. And it's a very, as you can see from the green around, picturesque site, lots of open spaces, which is unusual for London. The hospital was built first at this site in the end of 19th century, and most of our buildings therefore date from that time, as you can see from here. Some of the buildings have been derelict and they have been abandoned, and there are some others which are being used since the first part of 20th century. The reason this site was chosen was that in those days, if you had an orthopedic injury, the best you could offer the patients was lots of fresh air and not much else. And therefore, we have lots of fresh air. And it is a pleasure to work in this site where there are big trees, some wildlife, lots of trees and birds. And it's quite nice to work in this environment. This hospital, unfortunately, is going to go, and we have been promised a new under one roof campus, which should have its construction started in about a couple of years' time. We have a central London site, which is very close to the Royal College of Radiologists and the Oxford Circus central London site. And this is an outpatient facility with some imaging in it. So if any of you come to London, you're very welcome to visit us. Coming to the topic for today, osteoidosteomas, they are a peculiar entity. They constitute about 12% of benign bone tumors. In the general population, the incidence is between 1 and 2 per 100,000, so not common at all. But if you consider London itself has a population of about 10 million, which would mean that at one time there are about 100 patients who have this condition. It has been reported in almost all benign long and flat bones, and has a very typical clinical picture which every medical student who has read his surgical textbooks and every radiology trainee are very well aware of. Night pain, which gets worse while the patients are sleeping, they get sleep disturbances, they have problems playing sport, and the pain has a miraculous response to the use of non-steroidal anti-inflammatories. The tumor, despite its small size, is metabolically very active and produces lots of pain-producing chemicals, and hence the typical symptoms. The usual radiology, again, is very well known, and you have a cortical-based abnormality, which has a central radiolucent nidus, and surrounding that is the body's response to it, which is indicated by the presence of thickened cortex. This sort of an appearance is not seen in every case, and you can have a presentation like that, young child presented with left hip pain, and if you look very carefully on the left side, you can see a very thin periosteal reaction along the medial margin of the femoral neck with a small central radiolucency, which was the intra-articular nidus. Remember, the hip joint capsule attaches around here, so this lesion is present inside the hip. Because there is not much of a cortex, there is not much of a cortical response, and hence this particular appearance. I will draw your attention to this case, which we recently saw, a young child presented with a history which was typical for osteoid osteoma. And on plain X-rays, we can see that there is a well-defined radiolucency with surrounding sclerotic rim. Now, this is a very typical appearance of a non-ossifying fibroma or a fibrous cortical defect, which normally doesn't produce any symptoms. So his symptomatology was not in keeping with his plain film appearance, and therefore he was recommended to have an MR. And on MR, you can see the non-ossifying fibroma, but there's lots of edema in the femoral condyle, which again was not really explainable. If you look carefully, there is a central focal abnormality, which on a CT scan showed the typical appearance of an osteoid osteoma, i.e. a radiolucency with a small central nidus, which is sclerotic. So you can have a distractor present on the films, and you have to carefully evaluate the patient's symptomatology to get to the actual diagnosis. Before the advancement of CT scan and MR, the usual mainstay for diagnosis used to be whole body bone scans. Metabolically active tumor, lots of new bone formation, resulted in this typical picture of a focal lesion, double density, like a donut sign. And but nowadays, this is mainly used for problem solving or in patients who have not responded to one treatment, and not is used as a first-line investigation. CT scan, as I've said, is the gold standard to demonstrate the nidus. And if you have a CT SPECT, you can superimpose the metabolic part on morphology. And this is a very useful technique, especially if you want to impress your orthopedic colleagues. They think it's wonderful, with colors and pointing to where the actual abnormality is. So what are our treatment options to deal with this painful condition? You can treat them in the good old-fashioned British way, not do anything. Conservative, lots of painkillers, it will go away. You'll get better. That is the case, it has been well reported. These patients, if you don't do anything, just put them on non-steroidal anti-inflammatories, they will get better. How long it will take? We don't know. So not a nice thing, because sometimes these patients, because of delayed diagnosis, end up with the psychiatrists even. You can have surgery, but surgeon will invariably have to take more normal bone out in order to get rid of that small focal abnormality. And hence the requirement of a minimally invasive treatment plan. With the CT technology, it is possible to drill a small needle in the center of the tumor and connect the back end of that needle with a special machine which will heat the needle tip to 90 degrees centigrade, resulting in a burn which is diameter of about 1 centimeter. And if you place the needle accurately, that means you can just kill the tumor cells and not much else. So this technique was first reported in the late 90s of last century, and since then has been widely practiced throughout the world with fantastic results and very little complications. So I'm going to share my experience of Stanmore of some of these interesting cases. The various modalities you can use to burn this tumor, you can use the radiofrequency with a standard needle, which is what we use. You can use the same modality with a cool tip needle, which uses a flowing saline, which makes sure that there's no charring around the needle tip, and hence you get a bigger, larger diameter burn. You can just cause mechanical ablation of the tumors. You can use laser, cryotherapy, or microwave. There are small differences between all these. Laser tends to produce a more focal, more limited and contained burn. So if you're using for spine, it's very useful. Microwave tends to produce a larger burn, so perhaps you can use that for an osteoblastoma, which is a big osteoblastoma. I personally have not used these techniques. They are quite frequently used in RF ablation or ablation of liver tumors. Planning the whole procedure is very important. We tend to discuss all our cases with our orthopedic colleagues in a multidisciplinary team. We decide which patients should come to us for a treatment and which patients the surgeons should have a go for whatever reason. The consent and explanation of the procedure to the patient is done in the presence of their parents, usually their young children. So the presence of mother particularly is very, very important. I tend to spend at least 15-20 minutes with the parents to explain the procedure, the possible risks and complications. Sometimes these patients have to be positioned prone because they're present at the back of the body, and therefore the anesthetist is an important part of the team. We have a fantastic support, and whichever position I would ask of them, they will put the patient in. Putting patients prone in a CT scanning table is not an easy task, but they do remarkably well there. I'll explain briefly the lesion needling and how I do it, the burning procedure, and the aftercare in the coming slides. So this patient had a lesion present in the lateral part of femoral shaft. So this particular patient is lying with his right side down. The left side of the thigh has been cleaned with the skin cleaning, and the patient is ready to be draped. There's a little mark there, which I have put on, which indicates where the actual tumor is, deep to the skin. I use a Bonopti needle. This is a 13-gauge system, which has a coaxial mechanism. There is an outer green needle, which is the cannula. It has a central trocar, and it comes with a little drilling component. So once the green needle has gone through the skin, on the surface of the bone, I'll take the trocar out, put the driller in, and make a small little hole through the cortex, just about that long, to make sure that I'm on the right track to hit the nidus. So here I've got the green needle in the patient's skin. This would be scanned with CT to make sure that I'm on the right track. This is the driller in position, and you can see that it just sort of protrudes out of the central bit of the cannula by about 1 centimeter and a bit. And once it is on the right track, that is removed, and this extended drill is put through the outer green cannula. This has got a drilling length of around 5 centimeters, and is usually good enough to get the needle to the center of the nidus. If you want, at this stage, you can use a biopsy through, again, the coaxial needle. This is a 14-gauge biopsy needle, which goes through that outer green, and you get a small core. Usually, my experience has been that the biopsy is not diagnostic in most patients. So we only use it if we absolutely have to, and there is a doubt about the condition, actual diagnosis, which is not common. Once we're happy with the needle position, at this point, patients get a tachycardic response despite the fact that they have general anesthesia. Their heart rate will go up because it's a painful needle, and the anesthetist, they like to give some analgesics to top up the anesthesia. I then put a rigid treatment needle. As you can see here, This needle has got a plastic coating, and the distal 5 millimeters only is exposed. You can have one with a 1 centimeter exposed tip. This one is a 5 millimeters exposed tip. This needle goes through the tumor nidus, so ideally you want to see this bit going through the tumor. And once that's the case, an electrode is, it's a very thin wire through that. This is put through the treatment needle, and the back end of this electrode is connected to this machine, which is then set at a temperature of 90 degrees centigrade, and only the distal bit of the needle will have that high temperature. I tend to burn these lesions for 6 minutes, and after that, patients recover from anesthesia. Once they've had a meal and they've been to the toilet once, they're free to go. I give them painkillers, oral painkillers, for the next 3 days, and usually after 3 days, they're completely pain-free. Some patients don't need even the oral analgesics afterwards, after 1 day or 2. I don't tend to let them run around or play sport for 6 weeks if that's a weight-bearing lower limb bone. And after that, they're free to do whatever they like. I'm now going to show you some interesting cases. This is the first patient, 7 years old, presented with pain in the shin. And on plain x-rays, it was suspected that he has an osteoidostoma. This was a referral to us. So we did an MR. And on MR examination, if you look at the axial stir images, you can see that there is some edema present in the shaft of femur. There is a little bit of surface periosteal fluid signal as well. That's the bit which was the radiolucent lesion on plain x-rays. Coronal images show a similar sort of appearance. You've got lots of edema in the center of the tibial shaft. But on CT scan, the cortex was just thickened. There was no tumor nidus present. And therefore, we concluded that this is not a typical osteoidostoma and is more in keeping with a stress fracture. So this patient was not offered an RF treatment. He was just treated conservatively, and with weight, proper protected weight bearing, no sport, he improved his symptoms and there was no need for an RF. Why would some patients not respond to this treatment? In my experience, when that happens, it's usually one of the following conditions. Sometimes the tumor just does not respond. Sometimes it's a long nidus, and as I've said, the treatment radius is about 1 centimeter. If the nidus extends more than that, you will have to either treat him at 2 or 3 locations, or he will have a recurrence. Sometimes the tumors tend to regrow around the same site, and you have to make sure that there's no damage to surrounding structures, and therefore you sometimes just cannot treat it. The particularly tricky lesions are the tumors present in spine and the ones which are next to structures of vital importance, particularly nerves, important neurovascular bundles. Now, these are some of the cases which I found useful to try and demonstrate those pitfalls. The first patient, this is a 22 years old female who presented with pain in her upper chest at the spine, upper thoracic spinal level. And these are the MR images. And you can see that there is a little bit of low signal intensity on these T1 weighted images in her D2 region, thoracic vertebra 2. Low signal intensity, which on stir, you can see that there is this bright signal intensity in the pedicle and some edema which extends in the adjacent part of the vertebral body. This is a very typical appearance of spinal osteoidostoma. The lesion normally sit in the neural arch, and the edema extends through the pedicle to involve the adjacent vertebral body. The question here was, which bit is the nidus and which bit is edema? So on axial images, you can see the low T1 signal in the same corresponding location. T2 shows the same abnormality, but as we've discussed, the nidus is best demonstrated on a CT. So just concentrate on these axial images and see if you can identify where the nidus is. So at this point, I thought nidus must be here, and because there is a lot of sclerosis around it, and it's not particularly deep in the vertebral body, it's an easy target, and I can treat that. But these have to be carefully evaluated and planned. So continuing with our evaluation, parasagittal reconstructions. Again, you can imagine that maybe that is the nidus and it's a treatable lesion. Going further in, and you notice that little thing here on the posterior corner of the vertebra. Now that is tricky. Coronal images demonstrate a similar radiolucent focus. So in summary, we concluded that the nidus is actually not that lesion there, but it's this little radiolucency present further anteriorly. And this was a very tricky lesion because this is right next to the spinal cord. Remember, this is a 22-year-old woman who is otherwise fit and well. So if you put a needle in and you burn it for 6 minutes, I felt something like that. It's difficult. And after consenting with the patient, discussing, counseling with her, we decided not to offer RF because there was too much risk for a potential damage to the spinal cord. And she's being treated conservatively. It's not to say that if it is present in that sort of a situation, then you just cannot do anything. You can try, and if one of these conditions are met, they are within 8 millimeters of the treatment needle, you can try and put a second needle in next to the spinal canal and put some air in. And that air, or normal saline if you want, acts as a barrier, an insulating barrier for the treatment needle to make sure that only the tumor nidus is burnt and the spinal cord is spared. Another case, lesion present in the articular pillar, and a needle first is introduced to make sure there is an insulating layer, and then you can put the treatment needle in. If you use this technique, particularly if you're using air, which is a better insulator than saline, you have to make sure that no air leaks into the treatment needle itself. Because if it does, that will not allow the current to run and the temperature will not be raised. So you then have to put some saline down the needle and then carry on with the burning. Second case, 7-year-old child, typical history of osteoidosteoma, pain in the lower right shin, plain x-rays, and you can see carefully just that radiolucency present in the femoral tibial shaft. MR shows a typical edema on stir. Axial images demonstrate that the tumor nidus is actually a longitudinal one, which as you can see here. And on the T1s, again, you can see the longitudinal nidus. And on the sagittal and coronal images, you can see that the nidus is actually quite long. Now, this is a tricky one because sometimes these lesions have an associated nutrient artery. And which bit is the artery and which bit is the tumor? This can be difficult to evaluate. So here is the tumor nidus, and in the adjacent segments there is a north-south running radiolucency, which I thought was the nutrient artery. So that I thought to be the tumor, that I thought to be the artery, which was not correct, as I'm going to show you. So I just treated the tumor nidus, a very good burn, no problems, patient made an eventful recovery, but following treatment, his pain score reduced from 9 out of 10 to only 5 out of 10. I would have expected it to go right down to 0 or maybe 1 after 3 weeks. That was not the case. The parents were worried. They brought the child back. We did a follow-up scan. And here you can see the track of my needle. And this rim around that, which is the segment of the bone which shows the burn radius. And as you can see, this bit was clearly outside the burn radius. This patient needed 2 treatments and not 1. Another projection shows the same phenomena, burn and a little bit of residual nidus, which did not respond to the 1 treatment. That was the track, and this bit was below that, which was not the nutrient artery. It was just a part of the tumor nidus. So he had a second treatment, after which he was completely symptom-free. The third case is a teenager, 19 years old, presents with pain in his knee. Notice that the radiolucency here is not the typical osteoid osteoma location. It's present within the medulla. Lots of edema around it, present right on the growth plate. And from what Dr. Saifuddin told you yesterday, if you have a lesion which is centered around growth plate, like that, with edema around it, one of the differential diagnoses to consider is a focal abscess. So could this be a sequestrum with surrounding radiolucency and edema? We did a biopsy, and then at the same time, because he was under general anesthesia, put the treatment needle in and burned for 6 minutes. As is usually the case, the biopsy returned as non-diagnostic, crushed bone, not able to make any diagnosis, but his symptoms improved, but did not completely go away. The pain score halved, didn't go down to 0, and he came back after about 1 year. And after 1 year, because we were not sure about the diagnosis, he had a bone scan which showed that there was still activity present in the lower femur. A CT scan was performed, and you can see again nicely demonstrating the area of the burn. And the tumor, which was present in the center of the burn, has not responded. It's actually grown. So I'm not sure about the diagnosis here. This patient is being replanned for a rebiopsy. We'll use a bigger needle, and hopefully we'll get the answer, and probably again do another burn at the same time. Next case is a patient who presented with severe pain, which he described as the worst pain of his life, 10 out of 10, history of weight loss and systemic symptoms. His MR shows that the 7th thoracic vertebra has a focal rounded abnormality with lots of edema around that. You can quite clearly see on the stir sequence. Now this lesion, to treat that surgically is a nightmare. T7, vertebrectomy is a big operation, lots of morbidity. We thought it was not safe to needle that because of its exact position. If you can imagine, if this patient is lying, there's no way I can get through the pedicle, there is the nerve coming out here. You can probably try a perapedicular approach, go like that. So this is what I thought I would do when I tried to plan a scheme for him. The best way to do is not to get rushed in the MDT environment if you have a case like that. Bring the images, take the images with you, have a cup of coffee, slowly go through it, and try and think of a plan. This was a CT scan, and again, was not sure if I'll be able to do anything for him. But remember, if this patient needs a treatment, we'll have to put him prone. So what should we do? Scan him prone. And if you scan them prone, the whole alignment changes slightly. And maybe that slight change of alignment did the trick. And we realized that if you put him prone, there is a track available, and you can put a needle through that. This tumor was only 5 millimeters from the spinal cord. It's T7, remember, there is a cord there. It's not chordaequina level. We didn't put any saline down the track, but only used a 5 millimeter exposed tip. Treated for 6 minutes, and he made an uneventful recovery, completely neurologically stable, and his pain has reduced significantly. I did do a biopsy, and again, didn't get an answer. Next case is a 6-year-old girl. She had a longitudinal nidus. This, when we discussed in our meeting, we thought was going to be a Brody's abscess and a sequestrum, osteomyelitis, sorry, not Brody's abscess, osteomyelitis with a sequestrum. And hence a biopsy was performed, which confirmed the diagnosis of an osteoid osteoma. So then this was, because it was a longitudinal nature of the nidus, treated at 3 locations in July 2009. And in May of the following year, she represented with symptoms with a tumor nidus which looked like that. So we again treated it, and then next year she came back with a small residual nidus again. So she received a third treatment. I'm going to show you the 3 images of her. This was the first presentation. This was the second presentation. And this is the third presentation. Notice here that on the second presentation, this bit is normal. But on the third presentation, exactly close to the growth plate, there is a small tumor nidus. So this patient needed 3 treatments. My theory was that this tumor nidus regrew. There was no tumor here, but after a year or so, there was a small tumor there. So whatever caused the first tumor to form caused that tumor to regrow again. So that was an interesting case, which normally we don't do more than 2 treatments. If we have to, this one needed 3. So in summary, in the last 5 years, between me and my colleague, we have done 174 cases. We are doing this technique for the last 15, 16 years, but I only looked at 5 years data. And out of 174, by using this technique, 7 patients needed a second treatment. 1 patient, the one I showed you, needed 3 treatments. We had 2 complications, 2 skin burns, 1 for a lesion of the finger and 1 for the anterior tibia. If you want to do this, please make sure that you have adequate surgical and clinical support. You need to plan them well. Remember, the effective radius is around 1 centimeter, and you must ensure adequate overlap to cover the entire extent of the tumor. You have to be at least 8 millimeters away from the vital structures, otherwise you use some insulating material. There are some treatments which will not be responsive to treatment first time around, and there are some tumors which would regrow. But overall, give and take, given the advantages, I think it's a very useful technique. Thank you very much.
Thank you, Dr. Sajid. Now actually we'll go for the second presentation. The second presentation, leave the question to the end of the session. The second presenter, Dr. Iyad Fateh. Dr. Iyad Fateh is a consultant intervention radiologist, King Fahd General Hospital in Jeddah. Dr. Iyad graduated from King Abdulaziz University and did his residency in McGill University, Montreal, Canada, and did the fellowship in intervention also in McGill. And he is the program director in King Fahd General Hospital and also a member in the exam committee. I'd like to welcome Dr. Iyad. The presentation is approximately 25 minutes about the gynecological emergency.
Okay, thank you. Actually, the topic, I expanded it a little bit to include the interventional radiology role in cases of obstetric and gynecological disorders, including the emergency situations. So IR interventions are expanding into an impressive range of areas within women's health, both rare and common conditions affecting women of all ages are a target for interventions. Hysterectomy is no longer the first-line therapy as it was many years back. Obviously, some cases do require, I don't know why this is going on by itself, just let me... Can we change this to stop moving? Okay, I think it should be fine now. Okay, so where were we? Let's go back here. Okay, so the fact that a woman can keep her uterus at the same time try and treat whatever abnormality is there gives her the chance of still being able to reproduce and have children. The impact on reproductive health, particularly complications related to pregnancy, childbirth, and female fertility, are all abnormalities or conditions that can be treated by interventional radiology. The procedures that are performed, okay, I broke down the lecture into endovascular, transvaginal, transcervical, and percutaneous interventions. This is an overview of what I'm going to talk about. So I'll just have a look at that, and so including fibroids, hemorrhage related to tumors, postpartum hemorrhage, including the placental implantation and uterine AVMs, transvenous approaches involving congestion syndrome, varicose veins, and then these are procedures that... So just a quick note on the embolization materials that can be used in such cases. So temporary is gel foam, permanent involves coils, particles. So mainly our procedures that we do either use gel foam, coils, and the particles. Some cases alcohol and glue can also be used. So gel foam is a temporary embolization agent. I'm not going to go into that specifics because it's a long talk. Coils, again, are the permanent embolization materials. They come in various sizes and shapes. Vascular plug for larger vascular needs to plug larger vessels. And PVA as well as microspheres. They come presently in a variety of sizes and materials. And ethanol can also be used as a sclerosing agent and an embolizing agent. So starting with uterine fibroids, they're usually not an emergency. It's usually done as an outpatient basis. Most patients are women that are not that old. I mean, they're usually under 40 years old, but we've seen some as young as 23 years old and up to 50 years old. The prevalence is 10 to 40% depending on the area in the world, most of which are asymptomatic, and they find these fibroids on incidental examinations for other reasons. The 25% that are symptomatic usually have been complaining of these symptoms for many years, but some of which they just assume it to being her normal menstrual cycle and just trying to ignore it. But knowledge is power, so whenever they know more about these sort of diagnoses in the public, they can actually go and get them checked by ultrasound. Hysterectomies were previously the gold standard for treatment, obviously for multiple fibroids, and myomectomies for one or maybe two fibroids. So again, surgery was the primary method of treatment. There are several treatment options for uterine fibroids: endometrial ablation, hysterectomy, myomectomy, hormonal therapy, and uterine artery embolization. So like I mentioned, that many women don't actually get the appropriate or enough information from their treating physician regarding the different techniques that can be used. So this is one thing that should actually be improved on. I mean, you should actually give all the information out there and then have the patient decide, obviously, again, with the support from the treating physician. Patient selection. You have to ask yourself, are these fibroids causing patient symptoms? So I personally, and I think most interventionists, will not treat a patient that is asymptomatic. This is basically a symptomatic treatment. You don't take aspirin or anything if you don't have a headache. So if you do have headache, you take something for it. So think of fibroids as a headache, obviously, much more symptomatic, but again, and is childbearing an issue? Because if you do a hysterectomy, then chances are obviously zero. Contraindications and what does the patient really want. The symptoms of fibroids are variable. They include heavy bleeding, pelvic pain, pressure symptoms. They could be also mass effect on the bladder, on the rectum. And we like to think about our cases as being candidates for fibroid embolization when myomectomy is not possible. So again, it has to be discussed with the patient very clearly what the intentions in the future regarding childbearing are. Technique basically is just a femoral approach. We go with the catheter, selective catheterization of both uterine arteries, after which they are embolized after doing an angiogram on each side. So this is like a description for the ideal patient that you'd like to see, who has already children, is perimenopausal or premenopausal, symptomatic, has multiple fibroids, and the major thing is that fertility is not an issue for her. And sometimes women even, they would like a larger family, but the symptoms are so significant to them that they really don't care about that at that point. So it's all about talking with the patient. So this is the sagittal images of before and after T2 and a post-contrast demonstrating the large bulk of fibroids. And as you can see here, this is huge. They're all, most of which are intramural, and they're obviously causing compression pressure symptoms on the bladder, and then some, they're very close to the endometrium, so probably has a lot of bleeding as well. This is the angiogram. You can see that the uterine arteries are somewhat prominent, which is the usual case in cases of fibroids. Normal uterine arteries are usually much smaller and are not as well seen with angiograms or even on MRA. So the top row of images demonstrates the first two images demonstrate the pre-embolization, and the last image in each row demonstrates the post-embolization, both left and right. If you can just compare the change in the size of all of these fibroids on the 3-month follow-up post the fibroid embolization, there's a significant decrease in size and almost complete resolution of the patient's symptoms. The benefits of a pelvic angiogram, you can actually demonstrate the ovarian artery, as you can see in the second image with the yellow arrow. The ovarian artery plays two roles. One, you have to worry about reflux of embolic agents back to the ovary, which may risk the chance of embolization of the ovary and causing a premature menopause. The other thing is that actually can cause technical failure. When you embolize both uterine arteries, you can still have ovarian arteries supplying the fibroid, leading to suboptimal results. Okay, so as I mentioned, the fibroid can also be supplied by other arteries, such as the ovarian arteries. You can have technical failure by being unable to catheterize one or even both uterine arteries. Thus, it's a technical failure, which procedure will not done. Here, again, you can have spasm, you can have small tortuous uterine arteries, or just no access. Again, technical failure, you can just see this is an ovarian artery, which demonstrates enhancement and supply from the ovarian artery. Results, technical success is over 97%, and the clinical success, meaning response and the improvement of symptoms, 90% significant decrease in bleeding, and over 85% decrease in mass effect. So the average volume reduction of fibroids is usually 40 to 50%, and the overall decrease in the size of the uterus, 35 to 40%. Complications are rare. I think these numbers are actually even decreased now, since thousands and thousands of cases are being done. The main problem is probably the pain, which can be every interventionist and every pain control unit or anesthesia unit has different combinations, most of which are usually suffice in treating the pain related to the procedure. And like I said, primary amenorrhea, permanent amenorrhea, is under 2%, and it's that percentage when you actually do see the ovarian artery. I think it's probably even less when you don't demonstrate the ovarian arteries on MRA or actually post-embolization. Infection, post-embolization pain, and prolapsed leiomyomas, especially in the submucosal fibroids, are possible. The Society of Obstetrics and Gynecology of Canada, UFB recommends that this should be considered only in women with symptomatic fibroids, where surgery is not possible, and all this information should be disclosed to the patients before actually going in and removing the uterus. However, you could always, the risk and complications, hysterectomy always may be required. A gynecologist who is familiar with fibroid embolization should evaluate all the patients considered for fibroid. We actually see the patients in a clinical setting when they are referred from gynecologists, just to make sure they have all the information they need. Tumor-related hemorrhage, non-resectable tumors, palliative embolization is performed, especially in patients also who had previous radiation. So this is a patient with a significant vaginal bleeding related to a non-resectable endometrial cancer. So you have the images demonstrating the pre and post embolization. These could be emergent and they could also be slow bleeding, but it has to be treated at some point. Postpartum hemorrhage, this is one of the emergencies, one of the urgent referrals that we do get. Definitions, blood loss of over 500 ml during vaginal delivery, over 1 liter during C-section, or more than a liter of blood loss in the first 24 hours postpartum. Or obviously any bleeding that causes hemodynamic effect. Incidence is 2 to 4% of pregnancies and has a very high maternal mortality rate. Most of these would get hysterectomies in the past. Some of them still do, just to save the life of the mother. First line of treatment now includes conservative measures, but if these don't work, packing doesn't work. Honestly, if they should just pack them and try and get it embolized if this service is available. Again, ligation does work, but I feel it's not as effective as embolization, and sometimes the actual fact of ligation causes or leads to the embolization procedure being very difficult or impossible. So, early postpartum hemorrhage occurs within the first 24 hours. Delayed is between 24 hours and 6 weeks, all of which can also be treated. The main causes are uterine atony and cervical vaginal lacerations. These are for the early PPH, retained or adherent placenta, and the delayed causes. Embolization is effective in over 85% of cases. Basically, embolization of mainly the uterine arteries, anterior division of internal iliac arteries, or cervical vaginal branches. Depending on the urgency, sometimes non-selective embolization of the internal iliac arteries may actually be performed. Usually gel foam is a temporary agent for embolization. Balloon occlusion can be performed before cesarean section in patients that are suspected to probably have a complicated delivery. So here you can see 12 hours post C-section, and was planned for a possible hysterectomy. You can see a large hematoma within the uterus. Here, pre and post embolization, just over half an hour, patient was controlled and hemodynamically stable with the embolization performed. There's some pregnancy-related hemorrhages as well, other than the postpartum hemorrhage, AVMs, invading trophoblastic tissues and instrumentations, and complications of ectopic pregnancy evacuation. Basically, ectopic pregnancies, embolization doesn't have a big role, just used sometimes in abdominal ectopic pregnancies to reduce bleeding before surgery. Abnormal placental implantation is also part of the hemorrhage. In these cases, basically we can place balloons in the internal iliac arteries, which may be used if during surgery there is a significant hemorrhage. They can be inflated and give the surgeon time to ligate or actually find the site of bleeding. Or the embolization can actually be used by either particles or gel foam to control the hemorrhage as well. So it's varied from one place to another depending on the interventionist and the gynecologists or the obstetrician treating such cases. So this is a case with placenta previa and placenta accreta. In this patient, balloons were inflated in both internal iliac arteries to control the bleeding during surgery. Uterine AVMs, rare life-threatening conditions. They can be congenital and can be acquired. The first reported case was in 1926. The true incidence of traumatic uterine AVMs is it's very sketchy. There's cases out there, but there hasn't been a compilation. Before 1997, there were 73 reported, but obviously there is so much more now with the improvement of diagnostic imaging. I'm not going to talk about the congenital AVMs. The acquired are the more common, and they're usually secondary to uterine trauma from spontaneous abortion, followed by DNC, therapeutic abortions, uterine surgery, and intrauterine devices which have perforated or caused invasion of the vessels. endometrial carcinomas, and gestational trophoblastic disease. They may present with acute or chronic symptoms. Acute usually profuse vaginal bleeding, which may require transfusion in some cases, and recurrent abortions and poor pregnancy due to the hemodynamic variation that occurs within the uterus itself. So this is a case that we previously done. Did this case with Dr. Al-Hazmi a few years back. So she came in, and with the history, she had an abortion and DNC approximately 3 months before that. You could see the high flow within the wall of the uterus. MRI was done. Again, you can see the AVM here near the fundus of the uterus. So on angiogram, the left uterine artery demonstrated a large flow with large draining venous side. And the right side was involved, but not as significantly as it was on the left. So embolization was performed on both sides. These are post-embolization angiograms, post-embolization ultrasound a few weeks later, and the post-embolization is the first image you can see. It's almost non-existent except for a slight irregularity of the endometrium near the fundus. So completely resolved. Pelvic congestion syndrome, again, it's a problem with women that have chronic pelvic pains that obviously go through the whole list of pelvic inflammatory disease and a whole bunch of diagnoses. At point, this was a diagnosis of exclusion previously, and it wasn't actually treated as much. But now when we do venograms, you can actually see a significant dilatation of the veins within the pelvis, which are amenable to embolization. Results after these procedures, honestly, are still varied. I don't know, maybe I would say 50-50. Maybe other colleagues here who do these procedures have different numbers. But some women respond well, some women mildly, some don't notice any change. So it's still variable. Basically, the symptoms are non-cyclic pelvic pain for at least 6 months duration. Usually we do the venograms if it's not well demonstrated on ultrasound or MRI, and the diagnosis can be made at that point. It's done as a day procedure, and usually access could either be femoral or jugular. Here again, you can see that there's a significant dilatation of the pelvic veins. And this side, so you go through the left and the right ovarian veins. Embolization is done on both sides. This case was done using coils and glue. And there was some internal iliac reflux, so you can see that there's lots of connectivity in the venous system of the pelvis. Usually, technically, they're almost 100% successful, but the long-term clinical success, like I said, 50 to 75%. Again, vulvar varicose veins, same idea as the pelvic. They could, but usually you don't want to use very sclerotic agents. Sometimes they can be painful. So coils are used. And they can be ablated with alcohol depending on the situations. HSG, basically a procedure that's done either by interventionists or done by gynecologists to assess for patency anatomical defects in patients with infertility. Fallopian tube recanalization is also something that can be done in cases of infertility, and then you can demonstrate these obviously by doing the hysterosalpingiograms. I'm not going to go through this significantly, but it's basically catheters and specific catheters used with wires and micro wires. You can actually recanalize the fallopian tubes with a large number of successful cases. Excuse me. So here you can see that the first image is obstruction here with the wire in the right fallopian tube, and then you have a free flow of contrast through the fallopian tube into the peritoneal cavity. This is the last part of the talk. So you can have transvaginal biopsy or drainage procedures. I honestly don't do many of these, only a few. Again, we're working in a general hospital. We only get referrals for some of the gynae cases. But basically, usually reports have demonstrated that access good results, transvaginal, transgluteal, or transabdominal, based on the preference of the user. So just as a case, the patient had an abscess within the uterus. Percutaneous drainage was performed initially, and a drainage catheter was placed. At a later stage, transvaginally, a vaginal stent was placed, and then this catheter was removed here, demonstrating the free flow of contrast. Obviously, this is it was palliative to a large extent, but it's just demonstrating that it really can still be done. So in closing, in providing women with an option that retains their physical integrity and sense of femininity, IR opens the doors for more women to seek and find solutions for their problems. Because, I mean, having the only option is let me remove your uterus is not very pleasing, and some women would rather live with something rather than you taking something out. So it's very understandable. So with continuing innovations, and the future continues to look bright for the management of these problems. Thank you.
Thank you, Dr. Dr. Sajid will present his last presentation about CT-guided cervical injections.
Thank you very much. How many in the room can actually doing these procedures, cervical nerve root blocks? 1, 2. And how many in the room have suffered from brachyalgia, cervical spondylosis? Again, same numbers. It's a common problem, and unfortunately, trying to deal with it is not easy. And I'm sure my colleagues who use the same technique would probably have a similar sort of experience that we've had. The number of patients who suffer from pain going down their arm following cervical spondylosis is roughly 85 out of 100,000. It's a very severe pain, and patients who suffer from it have described it as if they want to chop their arms off. This is one of our spinal surgeons who does this day in, day out. He started having these problems, and those are his words. Thankfully, in a significant number of patients, the condition remains self-limiting. They are in severe pain for a few weeks, a few months, and generally most patients recover. Most patients, not all. Some patients would continue to suffer, and these are the ones I'm aiming this talk at, the management of these patients. If you have this intractable pain which is not responding to conservative treatment, what are our options? Everybody is not going to have surgery. So that's where image-guided injections come in. They have a diagnostic utility and a therapeutic use. And I'll explain both in a minute. These patients are assessed with history and clinical examination. I don't have to go through the findings on conventional imaging. I'm sure anybody who's done radiology has seen examples of MRI demonstrating foraminal stenosis, signs of spinal canal impingement, and facet joint hypertrophy leading to canal stenosis and nerve root compression. CT scans we tend to use for problem solving, especially in the preoperative phase, when for the surgeons it's important to know how much of the offending, obstructing structure is calcified and how much of it is exactly soft disc, because there's slight different surgical technique for both. Plain films, surprisingly, they are still very useful because you can use a weight-bearing projection, physiological flexion and extension views. You can demonstrate instability at both atlantoaxial and subaxial locations. And again, CT SPECT is coming in more useful because you can see the facet joints which are actually metabolically active, and then you can direct the needle on those facet joints to get a more longer lasting pain response. If you want to do image-guided injections, there are different imaging modalities available. You can use ultrasound. You can use a combination of fluoroscopy with ultrasound, with or without DSA, CT or CT and CT fluoroscopy. We tend to use CT fluoroscopy for these procedures. Because theoretically it is possible to cause a significant degree of damage to these patients, including stroke and even death, consent is extremely important, more important than the other injection procedures that I do. So we are proposing to send an information leaflet to these patients, which will be sent to them before the procedure. They can discuss the findings with their near and dear, their loved ones, any doctors they trust. They can go on the internet and do their own research. We'll put all the information available to them about the risks and the potential benefits of this procedure. On the day, once the patients come, they're fully informed, and I tend to like to sit with them and go through the images with them, because I believe it's important that they fully understand what's going to happen. And once they know, they do exactly as you tell them. They would be on the CT table, they won't move, and the procedure becomes easy. The skin preparation, I tend to use iodine-based, not chlorhexidine, because it's supposed to be neurotoxic, and the skin gets anesthetized with local anesthetic. They normally lie on supine posture, and the head turns slightly the other way from the symptomatic side. I tend to use a 22 gauge spinal or a 5 centimeter long 22 gauge needle, depending on the patient's neck and the length you need to traverse. Ideally, I like to park my needle in the posterior part of the neural foramen, just behind the nerve, because theoretically, again, it is one of the safer areas where there are no blood vessels. Always use a connecting tube so that once my needle position is correct, I don't have to move at all, and perform the injection of contrast medium by using CT fluoroscopy. Very important to always aspirate in the neck before you inject so that you make sure there's no blood coming out. You can have an intraforaminal spread of the medicine or extraforaminal. It doesn't really matter as long as there's no blood vessel right next to your needle. So this is what we end up with. We've got the 58 years old male, and it was the right C8 nerve root, so it will be the C7T1 neural foramen. You can see the needle parked in the posterior part of neural foramen. Contrast medium injected shows that there is a little bit of flow in the neural foramen, so very good position, and we inject steroids and local anesthetic. Same patient came back 2 months later for the other side, and this was done by one of my other colleagues, and he likes to do his injection in the extraforaminal location more, with the idea that there are no blood vessels which can be damaged. Well, I like to point your attention to this MR, which shows that in the area where he is injected, there are actually quite a lot of blood vessels, and some of them are traversing in the neural foramen. That's a nerve coming out, and there's a vessel there. So if you inject around there, you can still damage the blood vessels. You have to be very, very careful, and hence the importance of aspiration before you inject. Doesn't always mean that you're safe, but it's safer. If you're using CT fluoroscopy, one thing to remember is that the CT images that I showed you are 1 millimeter thick. Whereas the CT fluoroscopy, our machine is a Philips CT scanner, 64 slice, tends to give 7 millimeter thick slices. But still useful because you can see the needle in real time, you can inject contrast medium and make sure that there's no blood vessels getting outlined. And the contrast medium is actually flowing where you're supposed to see it. This patient, when I put the needle right next to the neural foramen, there was blood coming out, so I pulled the needle back. There was no blood here, and injected contrast medium there. It was mainly for diagnostic use, and it worked quite all right. Sometimes it's very difficult to put the needle in the posterior part of neural foramen and staying away from the artery. In this patient, this is the neural foramen, that's the vertebral artery, this is the C6 level, and if I put my needle there, that's a nerve and that's a vertebral artery, so it's very difficult to be safe. And therefore, we decided to enter the cervical facet joint, injected contrast medium, which shows the outlining of the facet joint itself, and flow in the extradural space. So if there is a very, very tight neural foramen, you can use some indirect approach by using this technique, and it works equally well in these patients too. We have been injecting up till now 40 milligrams of triamcinolone, which comes with the trade name of Canalog, which is a particulate steroid, and dilute that with 0.5 mils of 0.5% bupivacaine. It's always a very slow injection because you don't want to disrupt any vessels, you don't want to cause any vascular spasm. Once the patients have had their injection done, their symptoms are monitored for up to 30 minutes in the department, and if they're well, they're free to go. They're asked not to drive for the rest of the day, and from the following day, they should be back to normal. The potential risks are the relatively less serious ones, i.e. arm numbness and weakness, a temporary worsening of pain, some allergies, vasovagal phenomena, Horner's syndrome I've seen once. But the more damaging ones, the more serious ones, of course, are damage to the spinal cord, possible stroke, even death. It's all been reported. How frequent are these serious complications? Well, these are the two studies which were surveyed by the pain management people. Remember, they are the ones who are using fluoroscopy for their guidance. And they quoted quite a high complication rate, 1.64% in one study. And in a big survey, 61 of the 287 departments sent the questionnaire had seen or they knew of a serious neurological complication. Remember, all of these were fluoroscopic guidance. Why do these complications happen? Well, either you've injected the vertebral artery because of an incorrect needle position, you didn't know where you were. I've shown you how tight the neural foramen is, and if that particular patient had the needle in the neural foramen, yes, you can inject vertebral artery. Your needle may have moved since you thought that you were correctly and safely parked. You can cause embolization of particulate steroids, which is a problem, and you can contribute to vascular spasm by being a para-arterial injection. There are also some studies which quote neurotoxic effects of local anesthetics and the preservatives used in steroid preparations. They can all cause problems. So I think it's important at this point to get a quick revision of the blood supply to spinal cord, because that's where all the problems arise. There's the anterior and posterior spinal arteries. The segmental supply normally get contributions from vertebral artery and from branches of cervical and transverse cervical and deep cervical, which are branches from the subclavian. Anterior spinal artery supplies about 75% of the cross-section of the cord. If you park the needle in the posterior part of the spinal neural foramen, you should be safe, and therefore a CT scan is a much better guidance. So the diagrammatic representation of the blood supply, notice the big area supplied by the anterior spinal artery, and notice the branches from the arteries which are not the vertebral but the other branches of the subclavian, which contribute to the neural foraminal blood vessels. This is what we're trying to get the needle, just park in there, well away from the vertebral artery, behind the nerve root. Okay, so far so good, but what about exceptions? This group of anatomists, they studied 10 cadavers and 95 neural foramina and showed that in 3 to 4 patients, there were significantly large blood vessels present in exactly that part which I showed you, which is supposed to be safe. So not everybody will have their vessels away from the posterior part of neural foramen, according to them. In a study which has come out this month, Skeletal Radiology, a group from Korea studied 55 patients, and they used Doppler ultrasound to see vessels in the posterior part of neural foramen, and again found that in 4 patients there were blood vessels present exactly there. So how can you avoid causing damage to spinal cord and brain if you park your needle in the posterior part? I'd like you to point at 2 cases. This was a Stanmore case, which was done 2007 by one of my other colleagues. He's always used CT. He's one of the pioneers of this technique, actually. He's not working with us anymore. But he got this patient, who was 60 years old. He had a very good response from the injection on the right side. The patient self-referred and came back for the left-sided injection. So needle is very nicely placed, very tight foramen. Contrast medium shows a good flow in the neural foramen. That's the vertebral artery, which seems to be safe. Injected steroids, and the patient developed a stroke on the table, there and then, within minutes. Taken to the ITU. MR scan done 8 hours later shows a really large cerebellar infarct. It's another case. This is from literature. Same CT guidance. They used injection and posterior part of neural foramen and resulted in a ischemic damage to the spinal cord. So quite a devastating complication for a relatively less serious problem. Yes, it affects quality of life, but at least they can take care of themselves and they don't have neurological deficit. And this is what happens. What else can we do to try and minimize the risk? One of the theories is that the problems happen because of the particulate nature of steroids. Why do we want to use particulate steroids? Because they're supposed to be longer lasting. There's a better, longer lasting pain response. That's the theory. The steroid particles get aggregated, they stay in there for a longer period of time, slowly keep on releasing their steroids, and the pain-producing chemicals get neutralized. Well, those same particulate steroids can cause embolization, and they are the ones which cause this ischemic damage. So this group, they studied the size of these steroid particles, the commonly available preparations. You've got silestone, depomedrol, Kenalog, Decadron. And notice that all of these commonly available steroids, which people tend to use, the number of particles which are more than 10 to 20 microns is actually quite high in all of them. The only one which has got majority of particles in the 1 to 10 micron range is betnisol. This one's available with the trade name of betnisol. So if you have to use steroids, theoretically, using betnisol with a CT guidance should be the safest approach, and I think that's the one which should be used. Here are the pictures showing the aggregated steroid particles, methylprednisolone, betamethasone sodium phosphate, betamethasone acetate, triamcinolone. This is betnisol, the small particles, and that's Decadron. And the size of vessels we're considering, they are less than 10 micron at the level of capillaries, and these are the ones which will get blocked if you use the larger sized particulate steroids. And this was proven in an animal study which showed that if you injected the animal's vertebral arteries with particulate steroids, they almost always develop neurology. And if you injected those vertebral arteries with water-soluble, less particulate steroids, those animals recovered. So more proof that you should be using water-soluble. What about the theory that the particulate steroids work longer? Yes, they work longer according to these two separate papers, but the difference of patients is not statistically significant. And you still get the benefit of confirming the diagnosis by using those steroids. Well, how important it is to actually inject with the flow in the neural foramen. I've said that when I tend to use this technique, I don't particularly care if it's not going in the neural foramen. Yes, I would like to see it, but I won't change the needle direction as long as I can see that it's a perineural spread and there is no blood coming in the needle. So I've reviewed my practice, and out of 21 patients who had the injection of steroids with the intraneural foraminal location, 85% of them had a very good improvement of their pain score. And out of the patients who had an extra foraminal spread, a significant number, still a very good response. Not as good, 85%, 75%, but statistically, again, it is not a great deal of difference. Small number of patient group, but I think we have a significantly important data there. And as the work continues, I'm sure we're going to get bigger numbers to try and prove. It's very difficult to get the right sort of patients in each group, which are equal in terms of foraminal stenosis, the degree of disease, and then you're trying to compare pain, which is a very subjective response anyway. But still, I think it helps to prove that. What else can you do? Well, instead of doing this risky procedure, you can try and inject in the posterior part of facet. Still, some medicine will go around the nerve, and you will away from all the important vascular structures which are present anteriorly. So this group, they published their study that instead of doing that, if you inject behind the facet joint, and you'll get a good response. And their studies, again, they confirmed that yes, it's not as good a response as the intraforaminal spread, but it's still quite all right. So, in the end, is it worth it? Getting such a heartache to try and treat a relatively less severe problem in terms of the fact that it's not life-threatening. It's affecting quality of life, but it's not life-threatening. And what we do, we can cause them a significant morbidity. Is it worth it? I think it is, but you have to make sure that you work in a center where if you have a problem like that, the patients can be taken care of, or you can send patients somewhere where they can be taken care of. Have to have very, very good communication, both with the clinicians and with your patients. Careful assessment. Do discuss the images with your patient sitting with you. Send them the information leaflet. Make sure your needle doesn't move if you're using this technique. I would suggest please don't use particulate steroids. The data is against them. Very slow injection. I don't like to sedate my patients because I want to make sure that neurologically I'm always able to assess them by talking to them. One group tended to use a test dose of local anesthetic. I think it'll be a problem because you want to be spending as little time with the needle as possible. You have to have the facilities for resuscitation. And if a severe foraminal stenosis, please consider injecting indirectly, either in the facet joint or behind the facets. I think you'll be all right. Thank you.
Thank you very much for both speaker, Dr. Sajid and Dr. Iyad. Please join us here, Dr. Sajid. We will be able to take few questions since they kept really their lectures on time. So, can we have the first row, please?
Thank you, Dr. Sajid, for this excellent presentation. I have a question because of the pre-osteal reaction. Sometimes it's so extensive that I cannot penetrate into it. So what's the maximum cutoff point of the maximum pre-osteal reaction in centimeters that you say I'm not going to do it? And for the osteoblastoma ablation.
Talking about the osteoblastoma.
Yes.
I do have access to a motorized drill. So if I have to use it, I will. Because when I started off, my instructor told me that always put double gloves on because that will avoid putting blisters. You still get blisters. It's hard work. So after about 2 years, I said enough is enough. I'm going to be using drill. So if it's a thick cortex in tibia or femoral shaft, I can't give you a number, but I would say more than a centimeter and a bit, I would use an electric drill. And as long as it's difficult to be accurate in guiding your needle in the small nidus if you're using a motorized drill. So I would start off with a manual one, and once the periosteum has been breached and there is a little track which can keep the motorized drill needle tip in, then I'll switch to electric drill.
Yes. Dr. Sattam.
Assalamu alaikum. Thank you very much for the presentation. Regarding the facet injections and the neural blocks, how many levels can you do at the same time in one session?
Yeah.
The perineural block, how many sessions do you do in the same setting?
Two things here. One is facet joints. With facet joints, I have injected 6 maximum in one sitting. Okay. Both cervical and lumbar. When it comes to nerve root blocks, I normally do at least a maximum 2, but on the same side. I would never inject both sides in one sitting.
And what would be the interval between each session and the session after?
At least 2 weeks.
2 weeks.
We tend to get 2 weeks before they can assess what was the response. Sometimes, especially if there's a diagnostic component, you want to see which level is contributing how much to the symptoms. I would give at least 2 weeks before I do the next level.
Yeah, those patients frequently present with a lot of facet degeneration as well as disc disease, and it gets difficult to figure out whether a facet block or a neural block would be the way to go. how would you select which procedure to do for?
I tend to work with my clinicians and see what they've recommended. We've got pain management people and we've got spinal surgeons. So both those groups have their different importance referral criteria. Surgeons mainly like to diagnose things. Pain management people, those are patients who are not candidates for surgery. So we are more aggressive in terms of number of levels treated in the second group than the first one.
I have a question for you, Dr. Sajid, for the osteoid osteoma. We always face difficulties in cases of the digits, which are really challenging sometimes. And the other one is sometime in the epiphysis, which can be like in the younger patients, mainly in the elbow. And my concern is the one with the digit, because sometimes the needles is always a problem, because to hold and to sit in, because there is no soft tissue to hold into it. So, because most of the cases that I seen, I didn't see one of the digit cases that you have done.
No, I didn't show any fingers. We have treated fingers both in feet and in hands. And that's why the treatment plan comes in really handy. So the two of us who do this, we would sit together and we'll decide how best to approach. And as long as the treatment needle can be parked in the digit and the outer cannula is away from it so that you don't cause any skin burn, you can do quite easily. Not, I would say, not quite easily, with difficulty, but you can do them. We've not had to turn anybody away because we thought that it was not doable apart from that spinal case.
Yeah. I have done 3 cases of digits and I had no problem with them, but you know, to sometimes the manipulation, putting the needles and setting up the needle together, it's just
tricky.
Very tricky. Any other question? I have a question for Dr. Iyad. For the AVM malformations that we have seen, have you crossed any cases or anything that you have done onyx in it?
Okay, so I know you like the onyx now and use it for everything, but yeah, I think it's a very viable option because it's a well-controlled embolic agent. That case we did in Canada, so I don't think they would have approved of spending that much money on doing something you could with gel foam and particles. So, but I think it's a very good idea, actually.
Majid, do you want to comment because you're smiling? Well, I have one case really, which was intrauterine AVM, which was very challenging. This lady had lost a lot of bleeding prior to come to us for the first bleed, and she required about 29 units of blood replacement. And we started doing this, and I had to do it twice on her. But now, since I did her almost 2 years now, and she's doing very well. So
Onyx.
It is okay.
It was onyx?
With onyx.
How much does it cost?
A vial I think will cost about 5,000. I think I used about 6 vials on her. 5,000 riyal.
Still 5,000 pounds.
Yeah. You know, onyx now is used for everything. Last week I used it for epistaxis. So I think it's something that can be used.
I just want to thank Dr. Majid Ashur for some of the content in my presentation. But I was struggling with the automatic move, so I forgot. Thank you.
Any more question? Or with this, I think we are very punctual on time. It's already 3 o'clock. And I think they did really a great job with keeping on time. Thank you very much, and thank you for the organizing committee. Thank you for you, Dr. Masleh, and your groups. And probably we'll leave the stage for you. Thank you. بسم الله الرحمن الرحيم. الدكتور أحمد محمد النعمي، المدير العام التنفيذي لمدينة الملك فيصل الطبية واستشاري الأشعة التداخلية بمستشفى آسيا المركزي. حقيقة ما شاء الله تبارك الله، شيء يثلج الصدر أن ترى مراكز في المملكة أنا زرت كثير من المراكز في داخل المملكة وخارج المملكة، بس حقيقة ما رأيته اليوم شيء يبشر بالخير، وما سمعت عن النتائج والأعمال اللي يقوم بها المركز لخدمة هذه الشريحة من الناس أو من النساء بالذات. عمل يشكرون القائمين عليه، وأتمنى أن نرى كثير مثل هذه المراكز في مناطق مختلفة من المملكة. أنا أعتقد أنه رحلة السرطان هي رحلة طويلة حقيقة، وتبدأ يعني من أول اكتشاف المرض، وينتقل من المرض لكذلك العائلة والأهل والأقارب، فالرحلة هي رحلة لابد أن يكون لها وجهة معينة، خاصة الناس القائمين على مثل هذه المشاريع. وما سمعت اليوم عن رحلة الأمل اللي قدمتوها أنتم كذلك، أنا أعتقد أنها ستكون دافع كبير لإنجاح كثير من المشاريع الجميلة، وهذا أنا أعتقد أنها استراتيجية رائعة لو أنها وزعت في كثير من البرامج أو في كثير من المراكز حول أنحاء المملكة. والمشروع رحلة الأمل هذا مشروع رائع جدا، يعني أنا ما حتحدث عنه يعني، لكن اللي شفته وقرأته اليوم معكم يعني كان رائع جدا. هو من الأشياء المهمة جدا، وخاصة أنه إلى الآن في خلال ال5 سنوات الماضية ما عندنا دراسات على مستوى المملكة تبين مدى خطورة هذا المرض. كثير من الدراسات اللي عملت كلها اجتهادات مراكز معينة ونسب عالية جدا بمقارنة مع أنحاء العالم، إذا قارناها مع الولايات المتحدة ومع أستراليا ومع بريطانيا، يعني المعدل يصل إلى 0.30 أو 32 إلى 35%. بعض الأرقام تعدت 1%، وهذه بالنسبة لنا نعتبر أنها أرقام عالية جدا، ولكن أعتقد بوجود الفحص المبكر والتثقيف الصحي للناس، أنا أعتقد أنه إن شاء الله نستطيع أن نقوم بعمل رائع بالنسبة لهذه الشريحة من المرضى.
أنا اسمي ممدوح محفوظ علي إبراهيم، أنا أستاذ للأشعة في كلية طب جامعة القاهرة، ورئيس الجمعية العلمية للأشعة التشخيصية في مصر، وأنا مسؤول الحقيقة عن أماكن كتيرة جدا، ومهتم قوي بالتدريب والتعليم الطبي في مصر وبعض الدول العربية. الحقيقة دي أول مرة في حياتي أنا أزور مركز بهذا التنظيم والتجهيز، والحقيقة أنا يعني أكتر حاجة يمكن شدت انتباهي هنا إن إحنا كأطباء دايما بنتعامل مع المرضى على إن هم يعني مريض، وأنا دايما بيبقى بنغفل الجانب الإنساني عند المريض نفسه، والأهم من كده الجوانب الإنسانية الأخرى اللي في عيلته. ودي الحقيقة أنا يعني كنت يعني معجب جدا جدا باللمحات اللي انتوا أشرتوا إليها في أنكم انتوا مش بتهتموا بالمريض بس وبحالته النفسية، ولكن كمان بأسرته وكيف يمكن التعامل مع أولاده وأقاربه والجيران المحيطين به. ودي نقطة الحقيقة جانب إنساني عالي جدا يمكن مش متوفر في أماكن كتير قوي في العالم. هو أكيد أحد الوسائل اللي هي تساعد على الوصول بنسبة الشفاء من السرطان إلى نسبة عالية، بالذات وإن معروف عند معظم الناس إن مريض السرطان غالبا يعني ما بيكملش فترة ويتوفاه الله. ولكن الثقافة بتاعت السكرينينج وكمان ان احنا نحاول نكتشف الاورام مبكرا غالبا مش موجودة في معظم الدول اللي هي يطلق عليها الدول النامية او مش من العالم المتقدم. وكون ان ده موجود في المملكة ده شيء طيب جدا جدا، وان هي تعتبر دلوقتي one of the leaders في المجال الطبي في المنطقة، وكون ان في ناس مهتمية قوي بهذا السيكتور وبالكشف المبكر، وان احنا نوصل بنسبة العلاج او الشفاء التام الى ما يقرب مثلا من 90% او كده، ده شيء طيب جدا ويحسب للقائمين عليه فعلا. أنا شايف إن ده متحقق بنسبة كبيرة جدا ويرقى إلى أفضل المستويات اللي هي مطبقة في أمريكا وأوروبا، ولا يقل شأنا عن أي واحد من دول، خاصة وإن الخدمات اللي هنا بتقدم بالمجان، وده تقريبا مش متوفر أبدا في أي مكان في العالم. لازم يكون في جهة معينة هي اللي بتدفع التكاليف، سواء كان المريض نفسه أو شركات التأمين وكده. لأن كون إن الخدمة المتميزة جدا دي تقدم بالمجان، ده شيء يعني ما أعتقدش إن ليه مثيل في حتة. والله احنا نأمل طبعا في هذا، ولكن دايما احنا عارفين ان ثقافة الشعوب بالذات اللي هي يعني في الدول النامية وكده بتقاوم بشدة موضوع الكشف المبكر، وان هم طالما الشخص ما بيشتكيش من اي حاجة عمره ما بيفكر يعمل لنفسه فحص دوري وكده. زائد ان في نسبة لا بأس بها من البشر بيخاف اصلا يعمل لنفسه كشف لحسن يكتشف حاجه مستخبيه، في حين ان احنا لو عرفنا من خلال المركز ان احنا ننشر الثقافه دي بين الناس، هنبقى عملنا يعني جزء اتشيفمنت كويس جدا في حق المرضى وغير المرضى طبعا يعني ان شاء الله.